Hey everyone, and welcome to this podcast from MedVision. I am a medical student in the UK aiming to make engaging, concise videos and podcasts to aid your revision. Today's topic, pyloric stenosis in children. I aim to cover the presentation of pyloric stenosis, the relevant investigations and management options. So without further ado, let's begin. So, what exactly is pyloric stenosis? Well, in order to fully understand what pyloric stenosis is, let's briefly cover the gross anatomy of the proximal GI tract. So, as we can see, here is the esophagus leading to the stomach, and they are separated by the lower esophageal sphincter. Now, let's move on to the stomach. This curved portion pointing upwards is called the fundus, then leading from it is the greater curvature. And opposite to the greater curvature is the lesser curvature, and as we descend towards the duodenum, which is the proximal part of the small intestine, the anatomical structure separating them both is what we call the pyloric sphincter, aka the main culprit in pyloric stenosis. Pyloric stenosis tends to happen at around 3 to 6 weeks of age and is more common in boys than girls. There may be a history of poor feeding and failure to thrive, with multiple formula changes by the parents to try to combat this, but of course to no avail. On examination, you may feel an olive-shaped mass in the right upper quadrant of the abdomen or in the epigastric region. Some risk factors for pyloric stenosis include being a firstborn male, prematurity, and maternal exposure to macrolides. In pyloric stenosis, the circular musculature making up the pyloric sphincter hypertrophies, therefore resulting in an extreme narrowing of the pyloric lumen. As a consequence, the food digested by the stomach is unable to pass through into the duodenum, leading to an obstruction and therefore a build-up of food. As this food has nowhere to go, it leads to the characteristic projectile non-bilous vomiting. The reason why it's non-bilous is because the food cannot enter the duodenum and therefore will not mix with the bile from the gallbladder. Other key findings may include a family history of pyloric stenosis, tachycardia, and decreased number of wet nappies. When a child presents to you like this, the two most key investigations to order are a chemistry panel, where you should find the child is in a hypochloremic, hypokalemic, metabolic alkalosis, and an ultrasound showing a thickened olive-shaped pyloric sphincter. And here is an image depicting this. Pyloric stenosis is treated medically and surgically. At first, you must give the child IV fluid and electrolyte treatment, and then a pyloromyotomy, where the hypertrophic muscle fibers are pulled apart to maintain the pyloric canal. However, like with everything, there are some complications that must be considered. In the case of pyloric stenosis, some of these include a wound infection at the site of surgery, perforation of the stomach or duodenal mucosa, and an incomplete myotomy. But thankfully, these are rare. So thank you everyone. That concludes today's podcast on pyloric stenosis, and I hope it's helped. Please don't forget to like, comment and subscribe for more content, and leave some suggestions below.